to record. Now we are recording. We are joined today by the wonderful Marcella, who has agreed to tackle this exciting task of going over the most important aspect of Medicaid billing, and that is billing Medicaid. And next week we will be joined by Terry again. I'm going to skip over these slides. We're all familiar with them. We've gone through them every week. So next week is quality assurance and quality improvement, and there will be another Q&A session on that Thursday, November 10th. For folks who joined the last Q&A session, we got some really excellent questions. Hopefully it was helpful to the folks who joined. We really encourage you all to join again on November 10th. And with that, I will pass it over to Marcella.
All right. Thanks, Eva. Thanks, everyone, for coming today and looking forward to today's conversation. As always, questions come up, put them in a chat. Questions we can answer quickly, we will do so. Questions that we can't answer quickly, we will take down and get those answers for you. Both either send them out to you as part of this, depending upon the level of detail, or also go over it again in the Q&A session that Eva talked about on the 10th. So happy November, everybody. Today we're going to be reviewing billing structures and processes. We're going to talk about different billing options. And when I say that, I really mean what systems is your agency using to capture the information in order to create a claim. We'll talk about the CMS 1500 form. We'll talk about how to make sure that your Medicaid documentation is Medicaid compliant. And we'll look at some examples of documentation. So all of these different pieces, as you begin to set up what's called a billing system. At the end of the day, your agency has to have, and this is covered in your policies procedures as well, has to have a process and a system for documenting what it is you did, what time your direct services staff spent with the people that they're helping get jobs and helping get in or sustain housing, et cetera. And then how does that translate into a file that Amerigroup can pay you for based on the rates that we talked about in the earlier session. So next slide, please. Again, always jump in and stop. So when we did provider enrollment, remember you made a choice when you completed the provider enrollment process. You said, this is how we're going to capture this information. So I just want to link this back to the conversation that we had in session 2 when we talked about provider enrollment. So next slide, please. These are the options of which we're aware of. Your agency may have, or your agency may be in the process of purchasing what's called an electronic health record or an EHR. That usually is a broader comprehensive system that gives you a lot of outcome measures for your services, who you're serving, what demographics of people are you serving, helps you do an equity analysis there. All of the different both clinical care, clinical services, if maybe you're also a health center, maybe you're also a behavioral health clinic, as well as these services, the foundational community support services. You may also have just basically an electronic billing system. This creates invoices for you. This has to be HIPAA compliant, and we'll talk a little bit about that today, et cetera, but something that just captures your documentation system and translates it into. It's important to remember because the payment mechanism is different. If your agency is doing supported employment, you need a billing system that captures literally minute by minute. And we'll talk today about what it means to bill a 15-minute increment and how many minutes go into a 15-minute increment, because it's not as simple as you might thought. And then also what you have to do in order to be able to bill a per diem, because if you're doing supportive housing services under FCS, that's a different system. So you may have an EHR, you may have a simpler electronic billing system, you may have an agency that does this for you and you have to pay them to do the work. So you may continue to document the way you've historically documented, et cetera, and then that generates some kind of a file, maybe a spreadsheet, maybe some kind of documentation that goes to a third-party biller, and that third-party biller creates a claim. You may have your password protected spreadsheets. This is something that Amerigroup's been directed by the state to allow, but that's not something that most systems do allow at this point. You may even have, the Wayback Machine paper claims. But again, that is creating, literally Staples will sell you for very little money, 1,000 CMS 1500 forms. But I will say that that is really not recommended at this point. Most of the HMO systems are not oriented in order to use that. Amerigroup's doing that. They're doing their best with it, but it's not the way most of their system is oriented. Most of their system is oriented in order to capture, we'll talk about an 837P file today, which lets them know what it is you've done and how they pay you for that. So there are a couple of billing options you need to choose: electronic health records, billing systems, third-party billers, password protected spreadsheets, and ooh, like I said, Wayback Machine, paper claims. So next slide, please. So I'm going to talk, as often I like these first slides, let's get you through at a high level what everything is in this process in documentation and billing, and then we'll go into the details of what we mean by each of those. So your direct services staff deliver the service. I'm helping people get jobs. I'm talking to landlords. I'm helping people get into housing. I'm helping them develop a crisis support plan. I'm helping them implement their crisis support plan. Direct service personnel are delivering the service. Direct service personnel, they'll either out in the field or back in the office come back and they document the service. You may have a tablet, you may have paper, you may have whatever system you have, but you document. Marcello was in the field with these people at this time, from time A to time B, from 10 a.m. until 10:45 a.m. And this is what we did. It's going to be very important that that documentation in the service gets back to your service plan, and it's clear from an auditor perspective that whatever it is that you were doing in that time you spent with the participant, that it has something to do with what their goals are on their service plan. There needs to be a process by which the documentation leads to the creation of what's called in healthcare space a claim. Healthcare claim is healthcare for invoice, as what many of us who might have done grants in our systems as well. And it has to follow a very strict format, what's called the Center for Medicaid and Medicare Services, or CMS 1500 form, and there's a link to that form as well, but we're going to go over that later today. Your claims will be submitted to Availity, that's the Amerigroup clearinghouse, electronically. Ultimately, what this is an 837P file. So if you have an electronic health record, you have an electronic billing system, that system has a way in which to take that documentation that you've created and grabs the information that it needs to fill out the 1500 form, and then creates this file, which is what Availity is looking for, which is the 837P file. Amerigroup will pay your claims based upon approved claims. If you submit your claims electronically, they will send you back what's called an 835 file or an electronic remittance advice. What it basically says is you submitted these, let's say 10 claims in this file, and 8 of them are good, everything's fine. Amerigroup is going to pay you for those 8 claims. There are issues with 2 of those claims, and we'll talk about how to determine what those issues are and what issues can be resolved and fixed to be resubmitted, what issues may not be able to be resolved, etc. But they give you that information back in that 835 file. You review what the unpaid claims are, the reason for the lack of payment. You figure out whether you can change that so that you can get paid for that service or you can't. So for example, an individual who is not enrolled in the day of service, not enrolled in Medicaid in the day of service, that is not a claim that can be paid. There's nothing you can do to fix that. There are other things that you can fix. If you use the wrong NPI number for your agency, if you spell the name wrong, if the prior authorization number that you put on the claim was wrong, etc. Those things can be fixed, resubmitted, and then hopefully paid out. Your agency will adjust and resubmit claims and hopefully get paid for all, if not most of those claims. You'll get a payment as was set up in the contract with Amerigroup. That's your billing units of service under supported employment, $27 for a single unit of service or a 15-minute increment. And then per diems, I think it's 112, but we've got a slide on that later, for supportive housing services. Your agency should have a process built in here where you review to ensure compliance and sustainability. You need to have a process by which what got paid, and you're able to work with your direct services staff. They may have productivity requirements, and you let them know what's meeting, what claims are meeting, what's not. If there are common mistakes that you're making, you work to fix them. Obviously, this process of submitting and resubmitting claims delays your agency's payment. That's not something we want. So this is the big picture overall process. I'm going to get into some of the details now. Next slide, please. Oh, I also want to shout out, I see we've got Jacob Avery from Amerigroup on here. So Jacob, as always, please feel free to jump in. You folks are the ones that are doing this work every day and working with the agencies. So if I misspeak anything or you want to add anything, please jump off and tell us. Though most of this is from the Amerigroup Provider Manual. Whoever at your agency is going to be doing the billing needs to spend a lot of time and be very familiar with the Amerigroup billing billing manual. So basically, this is just a screenshot of what's on page 37 of that provider manual. It gives you the information about Availity. That's the clearinghouse, Amerigroup's clearinghouse. It gives you the payer ID, where you would mail paper claims if you would use them, but hopefully not, and just some information that you need in regard to Availity. All of this material is just grabbed from the Amerigroup Provider Manual. And again, if you're the billing staff for your agency, you want to be really familiar with that and follow the rules and the guidance. The easier, the more detailed, this is a very detail-oriented person job, but the correct you get this information, the quicker that you will be paid. So next slide, please. Excellent. Next slide. Okay, clearinghouses. What's a clearinghouse? A clearinghouse in this case for managed care is a separate entity that is basically taking electronic data information, or EDI, electronic data interface, or EDI. It's grabbing that 837P file, it's looking at it and saying, does this have all the information we need? Is everything done right here? Can we make a recommendation to the actual MCO Amerigroup in order to pay based on these claims? They aggregate the electronic information, they make sure that the claims work is submitted securely and accurately. Availity is the clearinghouse that Amerigroup is using. And again, this is just one more time where I have to shout out to the Healthcare Authority for having the third-party administrator model. I'm working with agencies in Minnesota and North Dakota where they're working with multiple different agencies, multiple MCOs, multiple clearinghouses, that this is one clearinghouse that you work with, one account that you've got to set up, one agency, one MCO that you're working with, and they're working hard in order to onboard providers. All is just a really, really valuable model here to make sure everyone can sign on. All right, so that is the role of a clearinghouse. So you'll be working with Availity. Amerigroup encourages electronic claim submissions. We do too. That is definitely the future. But they are also willing to work with all the providers. You need all of this information, and particularly the procedure codes for that CMS 1500 form. We talked about supportive housing services, the procedure code of 80043. It's a per diem. You can bill up to 30 days in a 180-day period unless you have an exception. The rates are there. Pre-employment services, employment sustaining services. You see, if agencies are in pre-employment, you have a different procedure code than if they're in employment sustaining. So it's important to know and have the prior authorization from Amerigroup for each of these services. Each claim also requires that prior authorization number. Claims that do not have a prior authorization number that matches the agency's information and the individual's information are claims that Availity will reject. And you can work with your Amerigroup FCS manager for additional support on this process. It's also more materials and help, more details on this. This is where I got all this information from the Amerigroup website in regard to this. Questions? Let me just take a moment because this is very precise, very important information. And Jacob, anything you or anybody else from Amerigroup wants to add here? All right. All right. Jump in at any time, but next slide, please. You heard me use one of, as we're learning here, healthcare is a lot of different acronyms. One acronym you're going to hear in the billing space is something called electronic data interchange. Your agency and provider enrollment has made a choice about how you will do electronic data interchange, and we've got more details on some of these processes in this slide deck from session 1. You submitted this information not only to HCA as part of getting your Provider One account, you also submitted more of this information to Amerigroup. Amerigroup needs the same information. You need to tell them for your contract, for your agreement with Amerigroup, how you are doing your EDI. And again, these are the same options we had before. You may have an electronic health record, you may have a billing system, you may have a third-party biller, you may have worked out another process with EDI for EDI with your foundational community supports manager at Amerigroup, etc. But it's important that you have this worked out, and when you I'm not sure if contractor is the right word, but when you set up your agreement with Amerigroup, that you have all of that information there, and this is the process that you are going to follow. If you change that process, etc., you need to be in touch with your FCS Foundation manager, and they're going to need that information. They're expecting data and information to come one way through one path for you. They've got their system set up, shall we say, when you're pitching for them to catch, etc. If you're changing how you do that, you're going to need to let them know. All right. So yes, so next slide, please. So one of the things we talked about was for the support of employment providers is billing in 15-minute increments. These are all federal requirements here. Remember I said 15 minutes isn't what it used to be. When you bill for what's called unit of service, that means that a direct service professional has spent anywhere from 18 minutes to 22 minutes with that individual. You spend less than 8 minutes with them, you are not eligible to bill. You have to spend at least 8 minutes with people. And for the 15-minute increments for 1 unit of service, if you have 18 minutes of service, 15 minutes, great. Then you've got to get another 8 minutes in before you're billing for a second unit of service. So 8 to 22 minutes, you're billing for 1 unit of service under supported employment. That's the $27 rate. When you've seen people from 23 minutes to 37 minutes, you are now billing for 2 units of service. And then when you see people from 38 minutes and 52 minutes, you are billing for 3 units of service there. Each of those units of service is under that $27 rate. And you may want to grab this slide for training for your staff. It's very important. They have to document the time they spent with people, the direct service, the face-to-face time, etc. And it needs to bill in these 15-minute increments. Your systems need to be set up so that the systems can tell, oh, Marcella was with Rayanne from 10 o'clock until 10:45. That is 45 minutes. That's 3 units of service, because what goes on that CMS 1500 claim form is how many units of service that you are billing Availity and Amerigroup for. So I think just a really helpful detail there for agencies. Next slide, please. So people often ask us, hey, should we get an electronic health record? Is the investment worth it? As CSH does not endorse any one system over another, but let us say this. 1, you should talk to people who are using that system every day. I'm a full-time consultant now. I'm not using any of these systems. You shouldn't listen to me. You shouldn't listen to anybody who's not using these systems. You should always listen to people who are using it every day. You should have a startup period with them where you're learning the system. You should see how much of this system is customizable, how much does this interact with your other systems. You really want to make this system as easy as possible. You want your direct services staff to be focused on delivering quality services, not on messing with your electronic health record. You should have a process before you even go to looking at electronic health record. You should have and develop a workflow. Talk through your internal process. Does it make sense from a quality services point of view? Develop a documented written workflow that takes from service delivery to documentation to billing. Have that to start your conversations with potential vendors. Take recommendations from your friends and neighbors who are using these systems. Discuss with your team what you want, what you need. Discuss with different members of your team. Discuss with your direct services staff. Discuss with management. Discuss with development, because development's going to be trying to grab information here in order to, get additional funding for your services and programs, et cetera. What information do they need that they want to be able to pull out of their electronic health record? Think big and scale back is needed. Sometimes there's a big capital investment needed for this. Sometimes the systems will set you up for a long-term percentage of your Medicaid billing record. So you may or may not need that initial large capital investment. Schedule time with agencies who already use a system to discuss the pro and cons. Learn what the software does without any, what they call out of the box, not any individualized tailoring to your agency. And then what individualized tailoring might you want? What would that cost? What would that do to your timeframes, et cetera? What ongoing support is offered? What customer support services is offered? That's really, really important. Get estimates and schedule test runs, get references, and compare what it is you get from the cost. CSH has done for our work in Minnesota, housing stabilization services is what FCS is called in Minnesota. And we've got a link here to our guidance on HIPAA. HIPAA is a federal law, so it's very So it's very similar to what it is that you require. HCA is requiring your agencies to to be a HIPAA compliant, either an agency, what's called a covered entity, or also in the HIPAA world, what's called a hybrid entity. Hybrid means this department, this office is all doing the FCS services. That's HIPAA compliant. This office may over here may be running street outreach or a shelter. We're not billing Medicaid for that. So we're not HIPAA compliant over there, but the data systems, any data system that touches your FCS related records is going to have to be a HIPAA compliant data system. So the guidance on here can be, I think, really helpful. Get past the HHS language. Every time you see HSS, put in FCS, and you'll be seeing the same thing. And I believe, unless Rayanne tells me differently, we're going to be working on adapting this for Washington State for next year's work. So I'm hopeful for that as well. So just some things to think about, and know that this is a thoughtful process. Know that this process is probably going to take, to even pick an electronic health record and to pick how your system's going to go, is probably going to be at least 6 months. Build that into your work plans and your time flows and your time frames. Workflows and time frames. Get that. All right. Next slide, please. All right, we're going to talk about documentation. We're going to talk about a big important phrase called medical necessity. Everything that is delivered under Medicaid and that Medicaid pays for, there may be a requirement in regard to medical necessity. Melody, hey, Melody, nice to see you. You want to know if we're going to talk about collateral versus face-to-face. I believe we do later, and if we don't, let's make sure we do, because I remember having a conversation recently with Rayanne on this. All right, and great to see you, sort of. All right, next slide. Nope. All right, so as you look at your documentation systems, you've been doing housing related services for a long time, you're just starting a new system. Wherever you are in this process, look at your documentation. Look at the current state of what you're doing with client charts. Look at the location and the security of client charts. Remember, we said have to be HIPAA compliant. Those charts are probably going to need to go behind a locked door. Remember, you're defining medical necessity. Medical necessity is a constant conversation that says, why does this individual need these services? Why do they need these services at this level, at this amount, at this intensity? We're going to talk about the golden thread. The golden thread is basically the idea. What's in the service plan has to be covered in your documentation. Every chart, every note should say, these are Marcella's 3 goals related to her employment, and here's how the activities that we did today got her closer to meeting those goals. That's the golden thread between the service plan and the documentation, and that thread should be very, very visible to any outside entity that's looking at your charts. As you look at your forms, you may need to make some revisions. You may look at your intake and assessment. You may now be asking for some different information. What's an individual's Medicaid ID number? What are they enrolled in Medicaid or not? You're going to look at your individualized service plans. You want them to be able to link back to that, link that golden thread back. You may have progress note templates or things that you look at and work with that you may want to change based on what we talk about today and what Medicaid documentation requirement is it. And you may also have new quality reforms and tools. You may have somebody whose job it is to go through the charts and make sure the charts are reflective of the work and match also with your documentation for billing. That's going to be a really important process as well. We're going to cover some of that next time. But as you start this process, you want to look at your documentation and think about all of these things and think about what needs to change. Next slide, please. All right. So medical necessity, what's the definition of medical necessity? You're going to hear that phrase a lot. And here's what that term means when a person from healthcare, when a person from MCOs, an MCO like Amerigroup uses that. It means it's a provision of services that is consistent and necessary with improving symptoms or a functional deficit. Why does this person need these services? Why can't this person just go out a job on their own? Why can't this person just get housing on their own? What specialized support are you offering? Why are those services medically necessary in order for them to maintain their health first, maintain their housing, maintain their employment, all of which supports their health? Remember, Medicaid at the end of the day is an insurance program. FCS is the services program. Medicaid is the insurance program. You're telling an insurance company, this is why these services are necessary for this person to be healthy. It starts with a diagnosis of functional deficit. We can have big conversations about not liking functional deficits, but that really is the basis of Medicaid. It starts with an individualized service plan that your team's adopted with necessary and appropriate goals. That's where we get the golden thread from the documentation to the service plan and how those goals are helping people improve their functioning. There's a reasonable expectation that the intervention that you're offered will improve the level of functioning. Again, the goal is to help people be as healthy as they can. And as always, the documentation follows the golden thread. So next slide, please. So as you're thinking about documenting medical necessity, and as always, you get the slides, feel free to grab these slides and use them to train your teams. The client needs the service based on a diagnostic assessment. Here's what challenges the individual faces and why they need the service. There's a clear connection, again, the golden thread, connection with the service plan goals to the diagnosis to the assessment. These all fit in basic best practices in healthcare today. The writer in the progress note must explain the rationale, tell the story, why these services are necessary in order for a person to improve their health. A reader must be able to sit back, somebody who doesn't know the person, doesn't know your agency, doesn't know the service, but must be able to read that note and look back and say, oh, I can see the link. I can see the golden thread between what's in the service plan, between this individual's goals, and what was done that day with them. The progress notes are tied to the service plan goals, kind of the same thing. And the type and frequency of services are appropriate to the goals. So this is ensuring that if I'm helping somebody get identification, if I'm helping them navigate that process, I also link back to this person's looking for housing from an affordable housing source. They need ID in order to be able to do that. We're helping them get that ID so that they will be able to access the housing. Their goal is to remain housed. Their income is very low. They're going to need some kind of a subsidy for that, and they're going to need ID to document the subsidy. That really there is that thread between the person's goal, which is housed. Remember, be housed. Remember, goals can be very, very high level, and the little details of all the things we do every day to help them reach that high level goal. I like to think of those high level goals on a service plan as also, almost an umbrella, a really big umbrella that we can fit anything it is that we're doing to assist people under that umbrella. So next slide, please. So here's just another example of the golden thread. You've got your supportive housing or your supportive employment assessment. You've got your individualized service plan that says these are the functional deficits the individuals have. I know it's not very strengths-based. It's Medicaid. It's foundations in the system. Just want to shout out not liking it, but that's the way the system operates. Based on the individualized service plan, services are delivered, services are documented by a progress note, and then those progress notes are reviewed in the quality review process. In each of these, you can see that golden thread from that initial assessment, what Marcella's goals are for herself and her life, and through each of these pieces of documentation. So next slide, please. And I believe the state has a lot of kinds of golden thread, a lot of training and supports on that golden thread idea as well. So documentation, let's talk about those assessments. Let's talk about those service plans. We've got some examples of them that we're happy to send out to agencies. If you don't have one, feel free to grab and adapt for your agency. Next slide, please. So what's going to be important for each of these is that under foundational community supports, one, you consider eligibility. Why is this person eligible for foundational community supports? For supported employment, they need to have complex healthcare needs or some kind of healthcare related need, and there are risk factors that make it difficult for them to maintain employment. The employment assessment also includes that they have an interest, they're interested in a job, they want to work, that's part of their goals, etc. for their lives. Their current employment status, they may be unemployed, they may be underemployed, what their current income is, what they're looking to increase that income to. Housing type and homelessness status, you want to get that in there as well, even though this is under supported employment. And what are their strengths and barriers? What's going to make it easy for them to get a job? What's going to make it hard for them to get employment? And how is it you're going to support them? Very similar in supportive housing, you need the complex healthcare, complex needs, social needs, healthcare needs, that they're experiencing homelessness, they're transitioning from an institutional setting, or that they're using they're coming from residential services, they've had a lot of change in residential services, they've had a lot of housing instability. You want to document in your initial assessment how and why a person is eligible for the services based on the eligibility requirements. And then again, all of this information for the housing assessment, what's their employment status, their income, housing type, or are they experiencing homelessness? Oh, thanks for the golden thread training, Rayanne, appreciate it. personal information related to housing placement and housing history. Again, you are making a case for why these services are medically necessary for an individual to reach their goals around housing or employment. These are all part of your initial assessment. And as you look at your initial assessment, what I would do is basically take, here's your initial assessment and say, is this covered? Create a checklist. All of these covered in the assessment. If they're not for this program, as we develop an FCS program, we're going to need to design, we're going to need to either add some questions or redesign our assessment process. So how does an SUD diagnosis play into this? Well, an SUD diagnosis is one, helps you be accountable for that. So that would come under complex needs, complex healthcare needs. At the end of the day, it's going to impact, and you're going to want in the assessment understand, how does someone's substance use impact their employment status, impact their housing or homelessness status, and impact what services and supports you need to give them in order for them to be successful in these, depending upon wherever they are in relation to their substance use. So are they in contemplation stage? Are you taking a harm reduction approach to this? Are they in early recovery? Are they in maintenance phase, et cetera? You think about all of those pieces into it and integrate that into your assessment. When I say health needs, I mean a really big, broad, again, umbrella metaphor here. You want SUD, you want mental health, you want primary care, you want physical mobility. You want to understand all of those things, because all of those health related needs impact a person's ability to work, impact a person's ability to be housed, get housed, and stay housed, and impact why people are probably going to need your assistance in order to do that. That's why people are eligible for the program. Sherry, I hope that answered your question. And thanks for jumping in. Good chat with the question. All right. So you're looking at your assessment and making sure that these things are covered. Good. Sounds good. All right. Next slide, please. So service plan compliance. How do we make sure that we're putting together service compliance that can be covered by a Medicaid service? Next slide. I'm sorry. No, yes, here we go. Okay. Here are just some factors that a Medicaid compliant service plan will cover. You know what, bring them all up, Eva, because I think it's one of those, every little block here, et cetera. One, the service plan demonstrates the need based on the assessment. You've made the case that because of a person's challenges, they're going to need extra assistance to get housing, to get a job. Their client needs, your services will help them improve symptoms and their functioning. If there are problems and barriers related here, they will be addressed. Marcella doesn't have identification, but we're going to work with her through that process to get her identification. That will help her both get housing and employment. There are clear measurable goals. There are steps that you can be judged against, shall I say. You have that high level goal, which is basically an employment related goal or a housing related goal, but you also give smaller steps, that all of the things that you do to take you from here to there. You give smaller objectives to reach their goal. Again, these are all trackable. These are all measurable, and these are all reportable. You highlight the strengths of an individual. Gosh, every time I've worked with someone with long-term experience of homelessness or unemployment, the strengths that they've had in order to survive is amazing. You build up those strengths, you highlight those strengths. You've got really clear timelines. You think that you can get their identification, you think that you can get their copy of their high school diploma, you can get their resume written in this period of time, and then move them towards the process. That doesn't mean you have to. That doesn't mean if it takes longer, that's fine, but you're going to have to justify that and understand why. Oh, we thought we could get this person IT in 2 months. And then it turns out they don't have any documentation whatsoever. And this is just something in my own city that happened a lot. And their birth certificate is from Puerto Rico. Well, we found it took about 9 months to get a birth certificate from Puerto Rico. So that messed up our timelines, but we kept working on it. We kept supporting the person through that process. Roles and response. And why did it take that long? I don't know. It might have been there was a hurricane and everything was down. But anyway, I don't want to pick on Puerto Rico. Roles and responsibilities, who's doing that, who's part of your team, who's doing what, the person's doing this for themselves, they're getting help with that. You want all of that to be really clear. Again, you want it to be reportable, you want it to be measurable. You want somebody to come in, be able to come in and look at your service plan and say, oh, look, this is all that's happened. They are compliant with their service plan on these 3 areas. In these 2 areas, they're not, but we understand why. They've documented, they found new barriers, they're working through the barriers. You're always moving forward. What interventions you see and what progress and update. Timelines can be revised, interventions can be changed. As always, if a person wants something different, you change the story. Yep, everything's taken crazy long since Maria. Okay, I just wanted people to know I wasn't just picking on a, unincorporated space. So thanks, Sherry, I appreciate that. So yeah, so progress and updates. So yeah, so all of this you want to have in place in your service plan. Again, you're thinking about this both from a quality, how do you ensure quality services, but you're also thinking about it from an audit perspective. As a Medicaid service, people may be coming and auditing, people with no knowledge of you, no knowledge of your staff, no knowledge of your program specifically, just a broad knowledge of FCS have to be able to look at your materials and say, oh, I see the golden thread. I see how people are moving forward to housing and services and things like that. Next slide, please. All of these factors. Again, everybody's going to get the slide deck. You can use that to look. So what are best practices in service plan quality? You want to include housing stability and housing eviction prevention in your goals. They're coordinated with other providers. You want to avoid duplication. You want to avoid re-traumatization. We know healthcare, you go to 4 different healthcare providers, they all ask you the same questions. That's what I mean when I say re-traumatization. People have to tell their stories so many different times to so many different people. As much as possible, you want to minimize that. Serving service plan goals are a living, breathing. It's used. If it changes, it changes. That's great. It shows you're working with a person. It shows they've reached a goal. You're looking for another goal. It sets the framework for services. They're strengths-based, meaning you highlight what the survival mechanisms people have had. You highlight what they're really good at. You give them that support in that way. Services are all voluntary to reflect the client's own goals. One place, and this is really important, is language. I've seen so many service plans where so-and-so wants to be medication compliant. I promise you, no normal person in this world who doesn't work in healthcare uses the phrase medication compliance. You want it to be in their language. You want it to show that they've really been a part of this conversation and that they've moved that and that they've created this service plan. This isn't something we handed them. Auditors also look at, shoot, does every, service plan have the same 3 goals, phrased exactly the same way? That's kind of ticks off for, I don't think this is these people's language and what they really want. I think this is what the agency told them. So these are all really important things. You want to make sure it reflects their own recovery goals. Their voice is reflected in the plan. The goals are created with the client, not for, at the client. And the goals are reviewed with progress and barriers noted, and new goals are established and how you're going to get through those barriers. In some ways, you're never done. Even when somebody is maintaining housing, maintaining employment, you may have a crisis plan. People's recovery journeys are non-linear, what I would say, and you always have to be ready for the stressors of daily life and the challenges that can come there. So these are all just things to think about, and again, feel free to use as you're training your staff as they're creating those service plans for how to think about best practices in creating a service plan. So next slide, please. This is just an example, and we'll be able to send a copy of these if your agency doesn't have a services plan. This is just an example of one. You can take a screenshot of this and use it. Again, if it's helpful, go for it. Nothing, CSH again is not requiring anything. We don't have any authority here, but these are some of the best, as we've done this training in many places across the state and across the country, this is a good example of some of the best of the work that we've seen here.
We also very quickly shared over email and have added to the SharePoint folder for session 5 a FCS version of an individualized service plan for you guys to use and adapt.
Exactly. Again, for all of these materials, our goal is to make it easier for you. Nobody wants to start from scratch. Download, adapt, as Ava said, adapt it for your agency. So next slide, please. So documentation, let's talk about progress notes. Just a couple of slides. One, you want to make sure that this is a billable progress note. An auditor needs to be able to look at a claim and say, oh, this agency billed for November 1st, 10 to 10:45 services for Marcella. I need to go look at the progress note that says that and so that I see that that matches. So here's all things that need to be included in a billable progress note that supports your claim. The date of service, because remember your claim submission has a date on it. The start and end time for supported employment, because remember you're billing on units of service, how depending upon how much time you've spent with them, that will impact your units of service. For supportive housing, because you're billing in a per diem, you want to have the total time. I spent 50 minutes with this person, I spent 2 hours, however, whatever that amount of time is. You want that total time there. The location, is it in the community? Let me go back to Melody's question about face-to-face versus collateral. Let me say my definitions of understanding it, and I'm 90% sure I'm going to get this right. And Rayanne, please jump in if I don't. Face-to-face time, direct services time is billable time. Remember, we talked, I believe it was session 3, where we talked about doing time studies for supported employment. You're looking at how much of your staff's time is billable so that you can do appropriate revenue projections. That's face-to-face time. Collateral time is time when I may not be with the individual, but I am doing an activity that is based on that service plan and that goal. So I am calling a landlord and working with them. I have a release of information, of course. I'm not calling a landlord about a client without that release of information. I'm stopping by a job and talking to a person's supervisor there. That's called a collateral contact. I document that contact, and you can, correct me if I'm wrong, Rand, you can bill for that, though that cannot be all. I believe there's a limitation to how much of your contacts have to be face-to-face. I believe it's a 20%, could be 25. Rand, do you remember these details? Oh, should we look them up?
Yeah, I'm not incredibly confident about the amount, but you're absolutely right on the collateral purpose. And the biggest point is just to make sure that it's, a service that's easily tied back to one participant. And then you explain or have somewhere in there why the participant wasn't there, or why did you provide that service without the participant present with you, to make sure that it's just clear. And then of course, yeah, if everything you provided was collateral, you're likely going to get flagged in some sort of audit.
Forgive me for blanking on this, and thank you, Melody, for reminding me that this is all in the Amerigroup Provider Manual. So yeah, I think when Eva closes this out, I may go look it up. So yeah, face-to-face as in person or a Zoom meeting. I don't know that that's been determined yet. When I say face-to-face, I mean in person. I do not mean a Zoom meeting. This is the question around telehealth, and we would have to do a little bit of digging, or Jacob, or I don't know if anybody else is on from Amerigroup, if they know the answer to this question. If you're doing a Zoom meeting with someone, that is considered telehealth. And I don't know what...
I can help with this. For FCS services, things like Zoom or any kind of video conferencing, secure video conferencing meeting is considered face-to-face. And you can also build phone call as it is considered face-to-face, but is you are able to build phone calls over FCS services, even though face-to-face is considered preferable.
Yeah. Jacob, you were coming in and out. Could you
face-to-face services?
Could you put just a little something in the chat on this, just because you came in and out, I missed some words, and precision is all of this in this question. Is that possible?
I will, yeah.
Okay, cool, awesome, thank you. Let me also say, and Jacob, you may put this in some of your answers as well, is that there are rules right now. They're fairly flexible rules as long as we as a country remain in the public health emergency. It's not clear. Oh, for FCS services, video conferencing is considered face-to-face, and that means it's billable time. So yes, what I'm not sure, and we'll have to do some lookup as well, is whether the flexibility, some of that flexibility will go away when we are no longer in the public health emergency. Right now, we expect to be in the public health emergency until at least mid-January. What I will also say is that Face-to-face is considered preferred. Telephonic communication is also billable. That's from Jacob in the chat. Just wanted to say it because that's really important that you get that information. Oh, they're actually preceded public health emergencies. Okay, so Jacob, do you not think that this is going to shift when we get out of the public health emergency? I know states have a lot of flexibility around telehealth, and there's conversations at all sorts of levels, state and national levels, about what of those flexibilities will remain when we get beyond the public health emergency. So yeah, little rabbit hole, but an important one for agencies here. What else is in the progress note? The client name, the goals that the service activities are related to. Yep. Okay. Thank you, Jacob. There'll be changes at the end of the public health emergency, which we expect probably in early 23, but not sure. Watch your news for that one, but not around the above issues. That's helpful to know. Thank you. So the description of the service intervention, what did you do? What was the client response? What was progress? What was next steps? It always has to, a service note really never stands alone. It links to the service plan. It links to the next progress note, always links to your assessment. A dated signature from the individual and a title of the service provider, that the service is medically necessary. That's always a good line. Service date is with an approved and valid service plan date. Texting with clients. I have not seen an answer to this. I will tell you, Sherry, the first thing I would do is go to the Amerigroup Provider Manual and look and see if there's anything in there in regard to is texting allowed. But if anybody wants to jump in and answer that one, I would be grateful. That's a good question, Sherry. So yeah, and I'm going to keep talking, which is why I'm not able to go Google the provider or grab the provider manual. It actually lives on my desktop because it's really well done and there's a lot of detail in there. All right, so next slide, please. We're talking about progress notes. I'm not going to go off fangirl on the provider manual, which I totally could. Okay, what are you doing? You're focusing on the intervention and the services as relates to your goals. You're using simple, plain language. It's always good to have a couple of client quotes in there. You're summarizing the intervention succinctly but therapeutically. You're demonstrating you spent enough time with this person to accomplish the therapeutic intent. You didn't go, hey, pay your rent and walk away. No, one, it's definitely not going to be 8 minutes. And two, they probably need more than that. If just a little reminder would work, the service wouldn't be medically necessary. So make your case. Oh, Jacob, this is from Jacob. If folks can't see the chat, texting and email are billable only during the PHA. If this is the main form of communication, you need to let Amerigroup know so we can add it to the list that they maintain on the behalf of HCA. I think we really want to be clear that HCA is looking for the majority of your services to be face-to-face in person. But if there is a request from an individual, but client choice is the primary underlying value here, et cetera. So we want to make sure that that's sometimes those two can be in tension. I just want to hold that up. But yes, and so it sounds like texting and email billable, but only during the PHA. The client signature, can that be digital? How is that best documented? It absolutely can be digital. But you're going to have to take people through the process of a digital signature and work that out for them. And most systems that I'm aware of now, they use tablets. And they have people, click on things, their digital signatures in their electronic health record. This is another reason why you might want an electronic record or billing system. Yeah. So you need to document that. And Jacob's saying again, there needs to be reason face-to-face services aren't possible for the particular enrollment. You need to document that change. Oh, here's a good suggestion from Leanne. Thanks, Leanne. I would include who's going to perform tasks in the progress notes for accountability purposes. Yep, that helps from an auditing perspective. That helps from a supervisory perspective. So yes, you want to include the client's response. You always want to include client quote or two, and a good progress note. You want to focus on the facts. You don't want judgments here. You want to say, this is what happened. You don't want to be subjective. You don't want to be opinionated. You want anybody who doesn't know this person, who doesn't know you, to watch and say, yep, that's what I saw too. And you always want to have next steps in here and a plan for what the next steps are. You're never sort of leaving somebody hanging. You know when you're going to see them again. You know what you're going to do with them. You know they're on a path towards, thriving in the community, and what are the steps they take in there. You always want to have that vision front and center when you're writing that progress note. So next slide, please. So one of the things we said is justifying time spent, demonstrate, and this is a quote from the last slide, sufficient duration to accomplish the therapeutic intent. You want to think about the symptoms that are present at the time of services. Is there any training on being a non-biller? Connie, I don't really understand that question. I don't know why agencies would want someone to be a non-biller. You would, yeah, that just doesn't make sense to me from an agency perspective. You want to consider symptoms and present at the time of service. You want to integrate that in there. What are people experiencing? What are you helping them with? You want to think about clinical and best practice approaches used. You may have folks with serious mental illness, serious substance use disorder, co-occurring disorders. You want a lot of collaboration with their clinical behavioral health providers, and you want to help train and support your staff and working with people. And you want to think about what's the impact that the service had on the individual. How did it help them reach their goals? Caution to not pressure staff for productivity. We have seen too many cases, too many sad cases where that led to staff who did fraudulent notes. They make a 2-minute call, last 8 minutes. That's something that's also caught on ODATs. You really want to be sure that you've justified the time spent, and you can make a case for why that extra time is medically necessary. Next slide, please. These are just some project notes examples. The assessment, the client has limitations around daily living skills, specifically around regular eating and good nutrition. The service plan goal is to maintain proper nutrition, resulting in better health and housing and stability. And this is what happened. This is what happened. There's no judgment in here. There's just to what was I going to say? There's no judgment here. There's just facts. We went to the home. The neighbor said they were asking for food, which resulted in of their neighbors, which resulted in the complaints. They were served, they have no food. They helped the person write a grocery list. They took them to the grocery store to help them learn how to shop. We discussed the importance of healthy food, how to plan for meals. Case manager said that the client should be contacting the case manager instead of the neighbors if they run out of food, etc. And this is what the client said and how the client felt about it. They'll continue to follow up with the next appointment and talk about nutrition and eating and support. And the client also said she'd call the case manager if she was running out of food or maintains help or needs help in this process. Many, many times I spent in the grocery store when I was a case manager. Good memories. Next slide, please. This is just an example of how to do this. You see, there's no judgment here. There's nothing wrong. You know, no judgments is really, really an important piece of this. Persons is anxiety that causes them to be easily agitated when the boss gives them instructions. They want to maintain employment, so that you want to have strategies to learn how to manage that anxiety and not overreact to the situation. And again, details. What are the strategies? What are the breathing techniques? What are the thoughts? How do you manage and control your thoughts? And how to respond. So again, what happened? What did you do? Where did it happen? How did it relate to the service plan and the assessment that you've done, what you've done there, etc. And then where are your next steps? So again, and again, just some examples here. Again, you can use in your own internal trainings. And I would say both use them in the internal trainings that you do for your direct services staff, and then also say use them in supervision as examples if people are having trouble saying, oh, I went there and the place was a mess and everything was terrible. That's the judgment we don't want to see. I went there and there were clothes on the floor and there was food that was rotted. Clearly there's an intervention that's needed. Clearly we're going to do some work around that because that's not a healthy environment. And this is in many cases about their health. So next slide, please. Oh, we are done. I thought we had a little more, but no, we are. So we're just about kind of the first hour. I think, Eva, at this point, I get to rest my voice and I turn it over to you.
Absolutely. Well done, Marcella. Thank you so much. So up next, we've got the quality assurance and quality improvement session. That's going to be with Terry next week. And as I mentioned, that following Thursday will be a Q&A. I am going to stop sharing the slides and allow us to see hopefully some faces, definitely some names, and feel free to come off mute or type in the chat any questions you have for Marcella or Jacob or Rayanne about this session. So let me go ahead and stop sharing. All right. So what questions do you have for Marcella and company?
I'd love to hear from the group. If you're already using a system for billing, what are you using? Do you like it? What do you like about it? What's been good? What's been not so good? And somebody who's not as far along in the process, what do you wish somebody had told you 3 months ago, 6 months ago, etc.? Real life examples are the best.
Is anyone using a billing system currently? Katie says, we provide case management services. We do have face-to-face appointments to bill against for the hour, but many of our contacts are on a daily basis, less than an hour. Either on. Either on a referral call with other agencies or with the client and how to navigate a situation. Thanks for the comment, Katie.
I'll just jump in real quick and share a quick experience. Bayside Housing and Services, we're on the Olympic Peninsula in Port Hadlock and Port Townsend, Washington. And we've just been providing transitional supportive housing for the last 6 years. We're preparing to start our first permanent supportive housing program. And so we're at the very beginning of this process, beginning to look at all our systems, develop all this from scratch, determine what our organization needs to grow into in order to be eligible to begin billing. But in terms of systems, our case management and housing teams have been working on to get established on Get Help. And then we're liking the fact that that integrates with HMIS and helps to kind of put those two systems together. So we've one thing we've really liked about them, we've been working with them for I think about 8 months now, 8 or 9 months. And they've been very hands-on in terms of training our staff. And so that's been really useful. I can't offer much experience yet because we're not billing yet, but we've been very, very grateful to their staff and to all of the really detailed, like weekly sessions for many, many months of training, which has been fantastic.
Is there a link to that website, etc.?
If
you could put that in the chat and share with everybody, that would be great, Heather.
You bet.
Thanks so much, Heather. I see that Sherry wrote that she said, what EHR are folks using? We're doing Availity, but expect to add an EHR in the future. Are there ones that work better? And John responded with, we do use Availity, but it's very time consuming. Does anyone know if there's a way to upload data to Availity instead of manual entry? And Jacob has responded with, Availity and other clearinghouses do provide options for batch billing. This is probably the easiest way to bill, particularly if you have a large number of enrollees.
Yes, I can't imagine individual billing on Availity. If you get an electronic billing system or an electronic health record, what it will do is your staff are, entering into tablets or their phones, etc. Clicking the client, it will pre-populate. This is their date of birth. This is their social security number. This is their Medicaid number. This is their authorization number. All of that needs to be here. There's certain variables that you have to put in each time. What's the date? What's the time? Who's doing the service, etc. But then that creates that 837P file that Availity can just capture from a batch billing perspective.
Katie asks, can we bill for cumulative services for housing, for example, spending 20 minutes a day times 5 days, if documented?
So if documented, yes. The only thing that I would say here is remember that the services have a limit of what's called a service limit of you can only bill 30 days in a 180-day period. If people need more time and more attention than that, you can make a case to your FCS Amerigroup provider. Remember, you're arguing for why is it medically necessary that this person needs this more intensive level of services? What are the additional challenges, beyond average that they make? So that is possible, but you do have to make that case and live within that. Oh, thank you, Heather, for the Get Help platform. And you should have a process that says, you should have an internal process that says, okay, for each client, this is how 130 day, these are the 30 days in this 6-month authorization period. Gosh, we're at day number 27, we're at day number 28, and we're 2 months out from the new authorization period. What are we going to try to make the case? Do we think we can just see them a little bit? You have to have a process that tracks that, a process that thinks individually and clinically about each person and what their needs are, and then makes the case from a billing perspective. So 5 daily housing supportive is 5 different days in a per diem perspective. So you're billing for 5 days. You're not billing 1 day a month for 1 day for a 60-minute total contact. You're billing for 5 days. The issue is that you've got to spread it out across 30 days over a 6-month period unless you make the case otherwise. Yep. It's really important what Jacob said in here. 60 minutes is the recommended time. Our answer is 15 minutes is the minimum billable for a per diem unit. And just reiterate what Jacob said, any day you have billable FCS services, you are billing for that day. You don't add up days over time, so that makes that 60-minute period. These are all good questions. It's a real shift for people to start thinking differently about billable time. Billable time is, and this is session 3, this is the time study work. This is the time that people are doing things that are allowable under the service definitions that you're documenting and supporting.
And Jacob also responded that if you need additional units to provide your services, you can submit an exception to rule request. Any other questions while we're all together? All right, well, it looks like we all get about 55 minutes back. Oh, where can we access the slides? So Keanu, if you have already signed up for this training and have, if you're signed up for the training and I have your email address, you should have received access to our SharePoint site where we are posting the slides, where we are posting the recorded trainings, as well as other materials. If this is your first training that you're attending, I may not have your email on file, in which case I will need to add you to the site. It can take about a week to process. I can also email you these slides. So if you wouldn't mind dropping your email in the chat or sending me an email, and I'll put my email in the chat right now, I can add you. Great. So Keanu, if you wouldn't mind just going ahead and sending me an email asking me to add you and asking for the slides, I can go ahead and send those over to you. Same with you, Allison, if you wouldn't mind shooting me an email.
Hi, this is Dawn. I wanted to not so much make ask a question, but make a comment. When we were talking about face-to-face services and billing them and collateral contacts, CMS allows us to bill for time talking to employers with or without the individual. Face-to-face is what's preferred by individual placement and support. So even though it's not mandated per what Amerigroup is looking for as far as a collateral contact, for fidelity in the best practices, it needs to be face-to-face with employers. I don't know if that makes sense.
Thanks, Dawn. Yeah, that's important for people to understand. Other questions, other comments? And Dawn, thanks for joining us too. She is the expert on supportive employment.
Thank you, Marcella. Nicely done, by the way.
Not the most exciting thing, but we all do need to get paid.
Indeed. And remain out of trouble.
Exactly, and remain compliant. Sherry, do you want to maybe come off mute? Are there changes to consider that? I'm not sure what you mean by that.
Well, she was talking about the face-to-face.
Yep.
And especially with employers or other things. And I'm just wondering, given the change in how people work now, and that we do so much, like there are positions now that are in 100% remote. I just wonder if they're talking about any changes to that remote face-to-face always being the best practice, since so many places just aren't doing it now.
Sure. And that's a great comment.
Sorry, talking black there, I didn't mean to.
The IPS employment site, the IPS employment team is not looking to redo Fidelity at this point in time. So per Fidelity, contacts with employers need to be face-to-face. And I think we've all discovered over the period of time with doing so many virtual, Zoom, Teams, whatever, it is difficult, or at least more difficult, to develop a relationship virtually than it is face-to-face. The idea with individual placement and support in the evidence-based practice is developing relationships with employers. And so that's what the issue is related to face-to-face. Even if work is done remotely, there is still a lot in the way of face-to-face employer contact when applying for jobs. Not always, certainly not always. But the intent is to build that relationship whenever possible. Does that answer your question?
Yeah, we've now entered into a universe where how people develop relationships is changed.
Yes.
And I'm just kind of wondering, I mean, even things that used to be, and that now, with most medical care now, with them pushing so much for you to do telehealth visits, and it being, I would proffer that that's something we need to kind of float upwards as something that needs to be adaptive as we're considering preparing people to be employed and housed in the new universe we live in.
One of the things to be aware of is that the evidence-based practice has, I think it's now 28 randomized controlled trials. If it is changed now, then we're comparing apples and oranges. And I don't see that happening. I don't see the IPS Employment Center doing that. And I will say that I absolutely understand where you're coming from related to so many more activities being virtual than what they used to be. I've had the opportunity now to do some trainings face-to-face as opposed to virtually. Totally different scenario in regards to building relationships. Absolutely different scenario in regards to building relationships. And so, like it or not, it is still the best way to build relationships, perhaps quicker, more effective, definitely makes a difference.
We moved all of early intervention with little kids, with babies and stuff, even online. And so I think this will continue even as we get further from the emergency, that really to meet the needs of so many young people and younger clients, like they don't even talk on the phone. They text as a primary mode of communication. And I just think more and more, particularly well-paying jobs, are 100% remote. And so we have to think about that too.
I will say that an awful lot of the folks that we work with are not getting those well-paying jobs. They're getting people with more significant challenges that need job coaching. Yes, DVR is actually approved doing some coaching off-site, but if they're actually learning a task and you're supporting how they talk to their supervisor and that kind of thing, it's more likely still to be face-to-face. I do absolutely understand what you're saying. There's just an awful lot within IPS and within the realities of perhaps coaching folks as it's needed that isn't going to be done virtually. The other issue is, and I'm going to be very, very honest here with my bias, there are an awful lot of job developers that would like to do virtual period and never have to go to see face-to-face, employers face-to-face. We can't do that. You know, it ends up being such an all or nothing kind of thing. I currently see, as I do fidelity reviews, almost every contact with employers per agency being virtual. Can't continue that way, cannot. and so, you know, I would personally hate to see it going virtually as an option, because it's going that way already. I ended up going to an agency doing fidelity review recently. They hadn't even had 10 job placements in a year. Not even 10. And they had 2 staff. That's not okay. You know, you look at doing things with landlords. So much of that is not going to be virtual. It's going to be face-to-face.
Right.
You know, when you're handing over keys, when you're looking through the apartment, when you're doing things along that line. And so even though some of it will be virtual, absolutely, for fidelity, face-to-face is what needs to happen.
No, I totally understand that. I come out of the disabilities arena, and have had supported, you know, individuals with job coaches.
Right.
And when we went virtual at the beginning of COVID, trying to keep up with my supported employee was tricky,
Yeah.
to say the least. I just also have some folks in the disability arena, particularly with social anxiety and other arenas, challenges like that, where a virtual option is
Sure.
better meets the challenges posed by their disabilities.
Absolutely. Self-employment and working from home are still options. They will be, I'm sure, for the foreseeable future. I've worked from home in this job since 2018, and it's still going to happen that way. But I also know the changes in what's upcoming are causing individuals to spend more time out in the community again. A sad side effect of that, and I'm not going to yammer on, I promise, is that what I'm hearing from a lot of employment specialists at this point in time is that people are no longer wanting to go out. The job they want to do is out in the community, but they don't want to go out, whether it's fear of COVID, whether it's now anxiety has risen so high, because we lived through a traumatic event with COVID. We all did. It absolutely traumatic event. And people that we serve, the staff that we work next to, everybody has gone through that trauma, and it's harder to adapt to this new environment. Luckily, we can support the people on our caseload in order to help them to make the transition if it's needed. Lots and lots of jobs are still going to be face-to-face. If a person chooses a job that's not face-to-face, that's their choice to make. It's all about choice. But the jobs that are face-to-face, we're not going to be able to adapt them to virtual for.
Yeah.
So there's no one right answer. Keep in mind fidelity, keep in mind what you can bill for, consult with us for the rest, and we'll figure it out together. How about that?
Thank you.
You bet.
Thanks to you both for this very important discussion regarding how supportive housing and supportive employment may, adapt to the changing landscape. If there aren't any additional questions, I think I'll let you guys out a few minutes early. Thank you again to everyone who has attended, and we will see you next week for quality assurance and quality improvement. And I will send out, not send out the slides, you've already received them, but I will post the slides as well as the recording to this training in the SharePoint. And folks who are having issues accessing the SharePoint, feel free to email me. Thanks everyone, and have a good rest of your day.
Thanks everybody. Have a great day.
Thank you. Great training.
Thank you.
Thank you.